Hello, everybody, and thank you again for joining us. My name is Dominique Bossard. I'm the Game Plan Advisor at the Canadian Sport Institute, Ontario. Welcome to CSIO's Podium and Parenthood, Fertility and Family Planning webinar series. Tonight's session is titled Infertility Treatments, Understanding Fertility Treatment Options, and is presented to us by our community partner, Markham Fertility Centre. This is the fifth of 6 sessions in the series, and the recordings can be found both on the Markham Fertility Centre website and the CSIO's Resource Hub. At CSIO, we're committed to supporting people and performances on and off the field of play by prioritizing holistic person-first care. We're very proud to partner with Markham Fertility Centre to help provide support for athletes and sport-minded folks as you navigate through sport and through the childbearing years. So for today's session, I'm pleased to welcome Dr. Marta Wise. Dr. Wise is Quality Director and co-owner of Markham Fertility Centre and co-host of My Fertility podcast. She's a very passionate advocate for women to empower themselves with knowledge about fertility and their options for family planning. Thank you so much for leading our 5th session today. Over to you, Dr. Wise.
Thank you very much for having me. Today, we're going to be talking about infertility treatments, understanding your options, and we're going to be focusing in also on the situation in Ontario and around funding and costs and all that. So it is going to be Ontario specific. Today, again, we're talking about fertility treatments. Markham Fertility Centre, or MFC, we are a group of 5 physicians. We are all REI trained. So what does that mean? We've all completed medical school, done residency training in obstetrics and gynecology, and then gone on to do further subspecialty training in reproductive endocrinology and infertility. We are a physician-owned and run clinic, which is certainly a unique thing in Ontario, interestingly enough. We offer complete spectrum of fertility care. So what does that mean? We do IUI, we do IVF, we do donor egg, donor sperm, gestational carrier cases as well. We provide early pregnancy care through the first trimester. We have 3 full-time genetic counselors as well to help us with aspects of the increasing importance of genetics when it comes to talking about fertility. We're also unique in that all of our patients who undergo egg retrievals do so under deep sedation with anesthesiologists. So our patients are basically just comfier. We are affiliated with Dream Fertility in Oshawa. We're affiliated with Horizon Fertility in Aurelia. We have a satellite clinic in Barrie, and we are making plans to go up to Sudbury to improve patient care there as well. So stay tuned for that. Clearly, we really like pink. Hosted by myself and my colleague, Dr. Garcia. It's called My Fertility Podcast. We have now over 50 episodes out. You can see them on Spotify, Apple Podcasts, Amazon Music, wherever else you listen to podcasts, covering a lot of the topics I'm going to talk about today in a lot more detail. We share patient stories as well and sort of all the things that are going on in the world of fertility. If there's something here today that piques your interest, check out the podcast because I bet you we probably have a couple episodes on it. Today, we're going to be talking about timed intercourse. We're going to be talking about IUI. Then we're going to move on to IVF. And then we're going to talk a lot around sort of the financial aspect. So financial assistance, OHIP funding, what's the current situation in Ontario as well. To start off, I want to give a very kind of broad overview of fertility treatments to allow us to orient the big picture before we get into the more granular stuff. Now, this is a busy slide. We're not going to go through everything in it, but just to kind of give a brief overview here. On the left side, we've got ovulation induction and timed intercourse. And then we have ovulation induction with intrauterine insemination, or IUI. Then we talk about IVF, and then we talk about IVF specifically with this genetic testing, this pre-implantation genetic testing, or PGT. And we're going to talk about all of these things. But really, I want to get across this idea that when it comes to fertility treatments, although each treatment has a lot of nuances and there's a lot of considerations for each individual treatment, You really can boil down fertility treatments to kind of three big things: timed intercourse, IUI or inseminations, and IVF. Each of those plus minus kind of variations. I've written some main key points for each. This is kind of a nice reference slide that we're going to come back to at the end. We're going to start with timed intercourse. We're going to start on the left side of that chart. Timed intercourse, or TIC. Basically, we are helping, let's say, a couple figure out when their best days for intercourse are. So we're helping align intercourse with ovulation. Ovulation being that event where the egg is going to get released from the ovary. We're aligning intercourse with ovulation to increase the chances of conception, right? So we're increasing the chance of sperm and egg actually meeting. As part of this TIC cycle, we're generally going to be doing some kind of monitoring to figure out when ovulation is happening. And we may or may not be using some form of fertility medications. In a fertility clinic setting, especially at MFC, we're going to be relying on ultrasounds, transvaginal ultrasounds, meaning ultrasound probe in vagina to get a really good look at the ovaries, and blood work to really pinpoint that fertile window and that ovulation window. Those fertility medications typically are going to be oral medications, so pills. We frequently use something called letrozole as a medication. We're using this to either induce ovulation in people who have irregular ovulation, so kind of kickstart that process, or to do something called super ovulation. Letrozole is a pill. You take it, and it either is going to kickstart ovulation in someone who has very regular cycles or get you to ovulate or to release more than one egg at a time. If there's more than one egg present, there's more than one target for the sperm. So then our chance of pregnancy is going to go up. Timed intercourse cycle is really ideal for couples if the cycles are very long or if the cycles are irregular. If the cycles are greater than, 35, 40 days in length, somebody might benefit from TIC, or if the cycles are irregular and unpredictable. This is the person who might say, I have no idea when my next period is coming, or my period's coming every 2-3 months. That is really the ideal scenario. That's the kind of the ideal patient to consider TIC. Truthfully, TIC really is not recommended for couples with unexplained infertility. So let's say a couple comes to MFC, we do all the testing, and they get diagnosed with unexplained infertility. The literature suggests that TIC cycles really don't improve the chances of pregnancy. And so it's not really recommended very often. It's really for the people with those irregular cycles. Just a kind of another way to look at it. Personally, I'm a very visual learner, so these visuals are super helpful for me. Day 1 being first day of full flow, first day of period. You take the letrozole for around 5 days, usually starting cycle day 2, starting cycle day 3. We're going to do some cycle monitoring, blood work, ultrasounds, usually starting around cycle day 10. And then ovulation's probably occurring cycle day 13 to 16. You see that needle there, that syringe, that plus minus HCG. So sometimes we might use an additional medication to kickstart that process of ovulation, especially in patients where we're trying to minimize the amount of monitoring they do. So sometimes we use it, sometimes we don't. And ovulation occurs, and we're going to encourage, or we're going to schedule intercourse 3 times a rare big LH around that ovulation time. So that's timed intercourse in a nutshell. Timed intercourse is the least invasive, the least quote unquote unnatural, least medical intervention for sure. But on the flip side, it is going to have the lowest pregnancy rate, so the lowest chance of success. For the right patient, it can absolutely work. Timed intercourse cycles in, let's say, a patient with irregular cycles, with PCOS maybe, who is sort of between the ages of 30 and 35, each cycle of timed intercourse, that pregnancy rate might be somewhere around 15 to 20% per cycle. Not unreasonable that people have to kind of mentally prepare, mentally buy in, may have to do multiple cycles of timed intercourse before they have success. Moving on to IUI or intrauterine insemination. This is the next step along that complicated table I showed earlier. With IUI, we get a sperm sample. This is a masturbated sample. It's specially prepared or washed, and the sperm is placed directly into the top of the uterus around the time of ovulation to improve the odds of sperm meeting egg, which is fertilization. IUIs can be done in a natural cycle, meaning no meds, or with a medication like letrozole to increase the number of eggs released. Remember, as we said, more eggs, more targets for the sperm, better chance of pregnancy. IUI, the procedure itself is quick. It feels like a pap test or a pap smear. So speculum does need to go in the vagina. The person doing the IUI, again at MFC, it's going to be one of the physicians, is going to put that catheter through the cervix up to the top of the uterus. It feels, from the patient perspective, as I said, like a pap test. Really, there's no anesthesia, no downtime needed when somebody's doing IUI cycles. IUI is helpful because we're getting the timing right, because we know when ovulation is happening, potentially more eggs, right, with those medications. And we're getting more sperm way closer to where they need to go. In intercourse, the majority of sperm die off in the vagina. They never make it to the egg. When we do IUI, we're bypassing the vagina, we're bypassing the cervix, we're bypassing the length of the uterus to get the sperm a lot closer to where it needs to go. So it's got that big head start. IUI is helpful for couples who may have unexplained infertility. IUI can be a great place to start. Mild male factor infertility. So this would be somebody where the sperm is not stellar, but not poor. So for that mild male factor. Of course, we use it when we're using donor sperm in situations with somebody who is looking to become a mother on their own, or somebody who is looking at same-sex couple, let's say where they need to use donor sperm, similar process. Visually thinking about it this way, day one, first day of full flow, first day of that period. In this illustration, I've added in the letrozole. So again, taking that pill for the 5 days, starting cycle day 2, cycle day 3, starting to monitor, trying to find that ovulation time around cycle day 10-ish, let's say. Ovulation probably is going to happen around cycle day 13, 16. Again, maybe it's going to be happening naturally. Maybe we're going to be giving a bit of HCG to kind of trigger that, not necessarily to make pregnancy rates better or worse, really kind of more a convenience thing for the patient. And then we're going to do the IUI after we see that big LH hormone surge that's telling us, oh, ovulation's coming, or after using that HCG medication that's triggering that ovulation event. Comparing timed intercourse to IUI, for sure, IUI is a little bit more involved. It gets more procedural, let's say, than timed intercourse. IUI is excellent for couples, as I said, with unexplained, also couples where they may have difficulties with intercourse. So coital factor infertility as well is another situation where we may be looking at something like IUI. For a couple, let's say where the person with eggs is under age 35, with IUI, maybe using letrozole where you're getting one follicle, like one egg, maybe 2 eggs, that pregnancy rate per IUI could be somewhere between around 15 to 20% per cycle. So a little bit higher sometimes than timed intercourse. Not necessarily a overwhelmingly successful fertility treatment. When couples are considering IUI, I always say you kind of have to mentally prepare, mentally buy in that you might be doing this a couple of times before you have success. What I will say though is with IUI, the cumulative pregnancy rate, so the chance of pregnancy after 3 or 4 IUIs is so much better, right? And for sure, lots of couples can absolutely conceive by IUI. So I would say this is probably the most common starting point for couples who are coming to see us at MFC. Moving into IVF, we're going to spend a little bit more time on IVF just because it is a little bit more complicated and has a few more steps involved. IVF, otherwise known as in vitro fertilization. So a little bit of context, a little bit of history. This is Louise Brown as a baby on the left side and as an adult on the right side. She is the very first baby born via IVF. She was born in the UK in 1978. In the picture on the right, she's actually holding that very first incubator where she became that embryo. It was a really big deal back then. And if anyone is interested in hearing more about the history of IVF, you absolutely must watch the movie Joy on Netflix. It documents the story of the physicians and the nurse who helped create the first IVF baby, Louise Brown, the story of how Louise Brown came to be. And it's a fantastic movie. It's very, very good. The first baby born by IVF was 1978. So this is still a relatively new technology. So we don't have it all figured out, but we've definitely made massive leaps and bounds, which I just think is super cool. Okay, so back to talking about the procedures. In IVF, the eggs from the ovary are retrieved, meaning they're coming out of the person's body. They're going to get fertilized with sperm in the lab. It's happening external to the body. And then the resulting embryo is going to get transferred back into the uterus at some point. Sometimes gets called a test tube baby, although we don't actually use test tubes for this. IVF for sure is the most complex fertility treatment. It's the most invasive fertility treatment, it's the most expensive fertility treatment. But on the flip side, you for sure have the highest success rates when it comes to IVF. So there are the pros and cons that are always worth considering and that we are discussing with patients. Who should be doing IVF? If somebody has blocked fallopian tubes, they for sure need IVF. If the tubes are blocked, the egg and sperm can't meet. And so basically we're moving right to IVF. In couples where they have more severe male factor infertility, we may sometimes move right to IVF as well, just because we know that that's going to be the best way to give sperm the best head start so they can get to the egg. And we're using this also in patients with unexplained infertility as well, maybe where they've tried IUI and they have failed. IVF also is unique in that it's the only fertility treatment that we offer that can reduce the risk of miscarriage. In a fertility clinic, we may be seeing patients who have recurrent miscarriages. They may not necessarily have a infertility issue, like they may not have issues getting pregnant, but they have recurrent miscarriages. And so IVF is the only treatment we will offer sometimes because it actually reduces risk of miscarriage. IVF is also super unique in that it allows for bigger family planning and for planning of future pregnancies. When somebody does IVF, we get, let's say, a bunch of eggs and we make a bunch of embryos, multiple embryos. Great. If the first embryo leads to the first pregnancy, we might have extra embryos left over. And those embryos can stay frozen for many years. In fact, I believe there was an embryo that was frozen for greater than 20 years. And when it was thawed, it still led to a successful pregnancy. So, for couples, let's say, where they're hoping to have multiple children, they're worried about fertility in the future as well. IVF can be a great option because you can almost bank embryo now for use in the future for baby number 2, baby number 3, etc. Why is this important? Well, I've said this umpteen times, but we know that the age of the egg, the person who's providing the egg, that their age is the number one biggest predictor for fertility, hands down, whether you conceive via intercourse, like naturally, whether you're doing IUI, whether you're doing IVF. So if you do IVF sooner rather than later, you're hopefully going to get better embryos, more embryos, and you're better chance of hopefully creating all the embryos you might need for your complete family. And for sure, patients who are older, so let's say into their late 30s, early 40s, if you have baby number 1, let's say at 37, 38, 39 years of age, pregnancy is 9 months. If somebody is breastfeeding, they may be doing that for 6 to 12 months. It might be 2 to 3 years before they're able to come back and consider pregnancy for baby number. And, somebody who started at 38 may now be 40, 41. And suddenly those pregnancy rates, again, whether it's getting pregnant naturally, IUI, IVF, whatever, are going to be that much lower. And so for whom it's very important to have multiple children, this is a really important conversation to have. And one of the big benefits of IVF, maybe is not necessarily super obvious right away. Okay, so how does IVF work? We have to stimulate the ovaries to get them to grow a bunch of eggs. We're using medications, so something called gonadotropins, and we're using synthetic versions of hormones that the brain makes anyway, FSH and LH. That top picture shows you how the injections kind of work. Very often they're in these very pre-filled pens. It's a really small needle. It's very thin. While somebody is taking these medications, we're monitoring closely with blood work and transvaginal ultrasounds. This is a picture of an ovary that's being stimulated with medications. You can see the circle of black dots, let's say. Those are all follicles that are going to contain eggs that are growing. And so we're making those big circles get bigger and making the ovary. And that's for our stimulation process. Stimulation on average, maybe 10 to 12 days of medications. Next thing we do, the ovum pickup, OPU, sometimes it's called the retrieval. Basically, we need to get the eggs out. So again, at Markham Fertility, we have an anesthesiologist. They put an IV in his hand. We give deep sedation medication. So all of our patients are comfortable and sleep. We use a transvaginal ultrasound. It goes in the vagina and it has a small needle on that allows us to access the ovaries. Very often the ovaries are really easy and big and right there. And we're doing this under ultrasound guidance. The procedure takes 20, 25 minutes for this. And most patients are in the recovery room about an hour or so, and then they're good to go home. So the day of the egg retrieval, the lab is going to freeze the eggs, right? They're going to bring the sperm and the egg together. So ICSI, which you see on the left, is where the lab will take one egg, the lab will pick one sperm, and they will physically inject the sperm into the egg. On the right side, or classic IVF or IVF fertilization, is where the lab will take one egg, put it in a petri dish, and put in several tens of thousands of good swimming sperm and allow for a bit more of a natural fertilization to occur. I could talk for an hour about the pros and cons of each of these and between these two techniques. Neither one is necessarily better than the other. They both have their specific uses. They both have, as I said, have their pros and cons. This is nuances in the world of IVF that your physician will talk to you about in terms of what might be best for you. Next, these are in the lab. So the embryos are going to be grown out for anywhere from 5 to 7 days. So 5 to 7 days post-retrieval. Embryos that are going well, they're going to progress through these different to become something called blastocyst. A blastocyst, as we call it sometimes, is a big ball of cells, several hundred cells, where there's an cell mass and an outer cell mass or trophoblast. The inner cell mass to become baby, and that outer cell mass or the trophoblast goes on to become the placenta. We want to see those blastocysts between day 5 and day 7 of embryo development. And blastocysts are what we are freezing potentially for future use. When it comes to kind of the aspects with an embryo, there's kind of 3 options or 3 considerations. Option 1 is something called a fresh transfer. 5 days post-retrieval, sometimes we will do an embryo transfer, meaning putting an embryo into the uterus right away. That's option 1. If we have extra embryos, we freeze them. Option 2, sometimes we just freeze the embryos in that moment when they get to that blast stage because maybe the person is not ready to be pregnant right away. We've had patients who get like the flu the day before their embryo transfer and they're spiking a fever, and so we decide to freeze embryos. Sometimes we know that there's something in the uterus, polyp, fibroid, etc., that we want to deal with surgically before we do an embryo transfer. So we freeze all the embryos. just a matter of life. Somebody might have something going on in that particular month and they need to delay that pregnancy for a little while, no problem. The third thing is genetic testing of embryos, which we're going to talk about in a later slide. This is the embryo transfer procedure. On the left side, the ultrasound image of what we'll see. Somebody will come in with a full bladder. We put, again, that little catheter through the cervix into the uterus, and then we inject embryo into that perfect spot right up near the top of the uterus. We don't see the embryo itself on the ultrasound. We're just seeing the air bubbles that are around the embryo. On the right side, that image there shows that speculum in the vagina, which again allows us to see the cervix so we can get that catheter in. And so the position of the uterus, that ultrasound probe now being on top of the stomach. Embryo transfers for during patients aren't painful. They do not require any anesthesia. It's a little uncomfortable. There's a speculum in the vagina, which, is nobody's favorite, and the bladder is full, which creates some pelvic pressure, but generally extremely well tolerated. Procedure takes, 10 minutes potentially, so it's pretty fast. Another way to kind of look at the big IVF protocol and sort of how it's done. Now, I will say there are several different types of protocols when it comes to IVF, and this is an example of an antagonist protocol. 99% of cycles are antagonist protocols, which is why I've not brought up the different protocols. When you're seeing a fertility physician, they're going to review your individual history and they're going to talk about different protocols if there is something that is going to be best for you. Basically, left side, cycle day 1, again, first day of full flow of that period. You're starting those injection medications. Cycle day 2 or 3, let's say, there's going to be those monitoring appointments. You see those ultrasound probes, blood work gets done so that we can figure out, do we need to increase, do we need to decrease the dose? Are your ovaries ready? Like the follicles in the ovary, are they ready? Are they not ready? You can see those ultrasound, those black circles growing. So that's when somebody is having those great, beautiful growing follicles. That ovary on the right looks gorgeous. Eventually, once the ovaries look ready and we think that they're going to contain lots of mature, great eggs, we do the egg retrieval or egg pickup. In this situation, this is with a fresh transfer. So 5 days post retrieval, we're putting that embryo back into the uterus and freezing any extra embryos that we may have. Generally speaking, on average, people are going to take 10 to 12 days of medications. And there may be, let's say, 5 to 6 ultrasound blood work appointments happening over the course of an IVF cycle. IVF is certainly the most invasive fertility treatment, but for sure comes back with the highest pregnancy rates. Somebody under the age of 35 doing an IVF cycle, chance of pregnancy could be anywhere up to 60, 65, 70% in a cycle. I mentioned earlier that one important aspect of IVF is pre-implantation genetic testing, or PGT. So very broadly, PGT is a genetic embryos. And when we're talking about PGT for the general IVF patient, we're talking about checking the number of chromosomes, the general shape and size. Why do we do this? Well, with increasing age of the egg or increasing age of that egg provider, we know that there's an increasing proportion of genetically abnormal embryos that are going to get created. PGT helps us select which embryos have the best chance of sticking or in the lowest risk of miscarriage. Again, there are additional costs when it comes to PGT, and there are different types of genetic testing that are out there. PGT-A is relevant to all couples, let's say doing IVF. There are a couple of other types of PGT that are used in very specific particular situations, so I did not make slides on that. And when you're talking to your fertility physician, they'll determine whether another type of PGT may be helpful or relevant to you as well. But certainly PGT-A is a consideration for all patients undergoing IVF. PGT really is what allows us to have that lower risk of miscarriage. As part of PGT, we're doing that PGT biopsy. As I said, after day 5 to 6, 7 of the retrieval, we've got these blastocysts, these big ball of cells. The lab does a biopsy where they're going to take 4 to 6 cells gently removed from the embryo and they're sent for genetic testing. This does not harm the embryo's development. The genetic testing results take about 2 weeks to come back, so we freeze the embryos in the meanwhile until we get those results back. This is another reason why we might freeze the embryos and not do a fresh transfer, because the couple or the patient has opted to do PGT. Let's talk about the current situation in Ontario when it comes to funding and when it comes to financial assistance as for how we can help pay for these things. In Ontario, we have OHIP. Consultations with doctors, testing, surgeries as needed, are generally covered under OHIP. Timed intercourse cycles are again generally covered by OHIP. Medications are not covered, as they're never covered under OHIP. The medications that we're using in timed intercourse, especially those oral medications, are generally pretty inexpensive. And if it has drug plan or drug coverage, they're going to be covered by, I don't know, I would say for sure over % of drug plans. IUI or inseminations. Now, they're actually mostly covered by OHIP, the cost. The sperm wash is not covered. So to put sperm in the uterus, it has to go through this special processing, this sperm wash, and it is mandatory. That is not covered under OHIP funding, and the cost at MFC anyway is about $650. Now, that does vary clinic to clinic. So please, if you are considering this, it might be worth it to shop around a bit. IUI medications are not covered. If we're using oral medications, again, that letrozole, not that expensive. If we're using injectable medications, costs go up, but that's actually not that common. It's worth mentioning, as of right now, not all clinics have OHIP funding for IUI. So if you're listening to this and you're thinking about IUI, find out if your clinic has OHIP coverage or not. It may not, and it may be financially beneficial to transfer to a clinic that does have OHIP funding for IUI, because again, it is not necessarily all clinics. Even in that sperm wash, those costs vary widely as well at the clinic. So this is not like other areas of medicine. Okay, we're talking about IVF now. Well, in the province of Ontario, as of T15, I believe, OHIP does have funded IVF cycles, meaning that if you have a valid OHIP card, again, if you're a female under the age of 43, you're eligible for one cycle of IVF during your lifetime. And the funding goes with the female, is kind of how they did it. The intention of the program is that the person is planning to be pregnant at the end of the cycle, meaning that you go and do a funded IVF because you want to embryos for use in 5 years. Unfortunately, it doesn't work that way. The amount of funding is limited. So clinics have ways for funding for IVF. Right now, most clinics are at about a year to a year and a half. We're at about a year and a half right now. Let's say the time of being put on to the time of your funded IVF cycle. It's also important to note that there are lots of things that are not covered. So again, medications, genetic testing of embryo, PGT, and storage costs. Storage basically refers to the fact that if you have extra embryos that are frozen and we're storing them for some period of time, there's costs associated with that. So that's government funded cycles. Now, some patients might say, you know what? Up is a really, really long time. I'd rather do a private cycle. Some patients may say, you know what? I might do more than one IVF cycle to have a successful pregnancy or to build my family. So I'm going to do a private cycle while I'm waiting for my funded. Done their funded cycle, has not worked, and now they're doing a private cycle. Reasons why people might do a private IVF cycle. Generally speaking, the cost of IVF is going to be about $10,000 to $12,000. Medication costs, again, are the same, whether it's funded or whether it's cycle, again, can range from $3,000 to $5,000, depending on what dose somebody might need. Genetic testing costs also vary a lot based on the number of embryos that you're testing. It could be $3,000, $5,000, $6,000. Miscellaneous costs, really storage more than anything else, about $700 per year. It's important to note that different clinics do charge different amounts for an IVF cycle, and it may be worthwhile to shop around to get a sense of the clinic and their associates as well. New thing is that in 2025, the Ontario provincial budget created a new tax credit called the medical tax credit. So 2% of eligible medical expenses, including fertility treatment, qualify for a tax credit up to $5,000 per year. So this is something that you don't need to wait for. There's no wait list. There's no major application. This is just something that you're going to do on your own. And that's one way that Ontario is making fertility treatments more accessible to more Ontarians. As well, there's been some recent buzz that the government has committed $150 million over 2 years to expand access to services. So the Ontario Fertility Program, this funded IVF, started back in 2015, and they allocated a $70 million budget. Now, the budget has actually not increased in these 10 years. And obviously, the number of Ontarians, the number of people who need IVF has increased, hence these really long wait lists. So the government has now committed more money to expand access to services. Announcements have been made. We don't know how the money is going to flow, when the money is going to flow, what's that going to look like. But certainly, we're all really hopeful that wait lists are going to get shorter everywhere and they're going to be able to provide more funded IVF cycles. But we don't have any details on that. And as of right now, the wait lists are still long. Stay tuned. I think it's always interesting to talk about the future of fertility care as well, because IVF is such an incredibly dynamic and changing and evolving field. In the future, I'm hoping that we're going to get better at improving embryo selection to figure out which embryos are going to lead to successful pregnancies. There's lots of research going on on something called in vitro maturation, which is the idea of getting eggs to do IVF without having to do all those medications and stimulations, which would be super, super awesome. But again, we're not there yet. And then, of course, the big thing is around increased access. So more government funding. And actually, there's more and more employers that are increasing private benefits coverage for fertility treatments as well, which is really, really awesome to see. So lots of good things. I just wanted to go back to this slide that I started with kind of this general overview. We've got our timed intercourse on the left, then IUI, and then IVF. And then I put in IVF with this genetic testing with PGT. Timed intercourse, ideal for young people, maybe with irregular cycles or long cycles. Sperm is good. Timed intercourse is a great option. IUI can be a great option for patients, for couples who have coital issues, so they're unable to have penetrative intercourse, let's say for some reason. Same-sex partners, maybe where they're using donor sperm, single women who may be using donor sperm. We need to have open fallopian tubes. We need to have, I said, decent sperm, meaning mild sperm issues are okay, but we can't have severe male factor. Ideal for patients who are younger because we know they're going to have higher success rates. And that success rate, let's say, maxes out at about 20% per cycle. IVF, more expensive. We're going to be talking about IVF in patients who have maybe long duration of infertility, more severe male factor, more severe sperm concerns, blocked tubes for sure, maybe unexplained infertility. Maybe in older patients, let's say, who are hoping to have multiple kids, we might be talking about banking embryos for future. Pregnancy rates with IVF are excellent. Definitely a big jump over IUI if somebody is a good prognosis patient. Your fertility physician can help you understand what your personal prognosis would be doing IVF. When we add on PGT, this is great for patients who maybe have a history of recurrent miscarriages, couples who maybe have some sort of genetic issues in their family histories that they want to screen for. And again, if somebody has a genetically tested, otherwise known as a euploid embryo, the chance of that embryo working and sticking is upwards of 60 to 70%, depending on the quality of the embryo. And so that number can really give a lot of confidence to somebody that they're going to be able to achieve what they want. They're going to be able to achieve that pregnancy, assuming that that embryo has jumped over all of those hurdles to get there. Okay, so let's say you've listened to all this and you're like, you know what? I want to do things. So where do you start? Best thing, see your family doctor, like for referral fertility clinic. You don't need to do anything in terms of testing prep work. We got it. We got you. You're going to see the fertility doctor. We're going to do a medical history for you. Potentially, if you have a partner, we're going to do some testing, right? Because we want to learn about the sperm. We want to learn about the fallopian tubes. We want to learn about, hormone levels. And then we're going to start talking to you in follow-up about some of your options and where we can go from there. Wrapping up here. With fertility treatments, really anyone has an excellent chance of building the family of their dreams, which at the end of the day is the goal, right? How you get there maybe doesn't necessarily matter as much as actually building that family. And with these incredible fertility treatments that we have, we've come a really, really long way. We help lots of people, which is fantastic. You can reach out to me by email. And then, of course, we've got our Instagram. And then, of course, I plug the podcast one more time.
Thank you so much, Dr. Wise. If there's any questions, just pop them into the Q&A. And while we wait for that, maybe I'll ask you one just around some of the timelines athletes should consider,
Yeah.
specifically around the IUI and IVF. I'm thinking about younger athletes and people who maybe are still thinking they want to compete and with training and competition schedules.
Yeah, for sure. Absolutely. Intercourse cycles, IUI cycles can really fit quite well into your life. People feel well. There's no restrictions when it comes to training or anything like that, let's say. So they're super well tolerated. There are those morning cycling appointments. All of our cycle monitoring appointments happen early in the morning between 7 a.m. and 8:30 a.m. with the goal of people getting in and out because everybody's got something to do. You'd have to be in the area. So, around wherever your fertility clinic is to be able to attend those appointments would be the one caveat. Certainly, when it comes to IVF, it is more of a time commitment, right? And IVF medications can make some people feel bloated, swollen, just uncomfortable. You know, Running, jumping with big swollen ovaries is just miserable. So most people just don't feel like they want to do that. But it is a short-lived thing. Around the IVF process, you may be able to start your medications, do your retrieval, recover in the space of 3 to 4 weeks. The other important thing to consider, though, is as I said, with IUI or intercourse, you might have to do multiple cycles. So there are some situations where it may be more beneficial to move to IVF first because it actually ends up being more, let's say, time efficient in the big picture than needing to do 3 to 4 IUI cycles. And you're thinking about all those appointments and all those procedures as opposed to just doing the one IVF, where again, it's a bit more of a sacrifice over those few weeks, let's say, or it's a bit more of an impediment on your life, but you get that higher pregnancy rate in the end. For some patients, we actually go straight to IVF for that reason too. So really, I think it's just important to talk to your fertility doctor so they understand your situation, your calendar, and then we can work with you to figure out, okay, how can we make the timing work so that minimal interference on your life?
That's great. Thank you. And just along, I guess, similar line, just around the planning and the discussion with the doctor, would you say that it's recommended for people to do that quite young, even if they're not really at the stage of taking action just yet, but just to have the understanding of what's required, timelines, things like that?
I think that kind of comes back to fertility preservation potentially, right? 15% of couples will experience infertility. So it's not every couple. There are still lots of people who conceive naturally without issues, but having some knowledge around fertility, understanding what your fertility is like, is something for sure a fertility physician can help with. And then contemplating something like egg freezing, or let's say if you're in a committed relationship, freezing embryos for use in the future. There's no reason why somebody can't do IVF, freeze embryos now, but then plan to get pregnant in 2 years or 3 years or 4 years. I think it's always worth a discussion with a fertility doctor to learn kind of where you're at, what's going on, and what your options are. But again, we are going to be asking you, okay, when do you think you want to have kids? Are you in a committed relationship or not? What's your life situation? And then we can go from there.
Thank you. There's a question, who determines whether classic IVF is used or ICS?
Oh,
And
good
then-
question.
And then if doing PGT, how soon can the embryo be transferred, if not within the 5 days?
Okay. So IVF versus ICSI. Okay. So this is it's not controversial, but this is the kind of thing that fertility doctors still debate at conferences these days, right? What we should be doing, what's better. Everybody has a little bit of a different take on this. The guidelines, the literature would suggest that if the sperm is okay, then we should probably be doing conventional IVF fertilization. However, when you do conventional IVF fertilization, you can have something called total fertilization failure. So 2 to 3% of the time, even in couples where, let's say, the sperm is totally normal, you might do IVF fertilization and no eggs fertilize. And that is an absolute crushing situation to be in, because if the eggs don't fertilize, we can try and put the sperm in, do ICSI the following day, but the success rates are really low. It just does not work well. And that could be the end of the IVF cycle. That is a really, really tough position to be in. I will say at Markham Fertility Center, the vast majority of patients who are doing a first ever IVF cycle, we will often do half the eggs by IVF, half by ICSI fertilization. And really, it's because we are trying to get the best of both worlds, essentially, right? We want to try for IVF fertilization because maybe potentially it leads to better quality embryos. Because again, you got that natural selection type process that goes on between the egg and the sperm. But at the same time, we're hyper aware that sometimes the eggs and the sperm just don't come together and people need ICSI. And so we tend to do half and half. But again, at least at MFC, the discussion that we have with patients in terms of what their feelings are. The second part of the question was around PGT and timing. Let's say you have your retrieval, you get your blastocysts, and the biopsy for PGT happens 5 to 7 days after that. PGT results take about 2 weeks to come back. So as soon as we've got the PGT results, you can do a transfer with the following day one of the cycle potentially. It might delay transfer by about a month.
I just want to thank you once again for another wonderful session.
Thank you very much.